My 15-year stroke risk curve, number 1548, VPT 101, February 24, 2026, Gerald C. EclaireMD Foundation, category stroke and blood pressure. Preface, personal medical journey and scientific motivation. This article is based on my personal medical journey and long-term self-monitoring. For more than 15 years, I have rarely eaten rice, bread, noodles, or similar refined carbohydrate foods. These items are no longer kept in my kitchen. Only occasionally in restaurants do I eat a very small amount, usually no more than 2 or 3 spoonfuls. My carbohydrates come mainly from vegetables, and my average total carbohydrate and sugar intake is about 30 grams per meal. More than 17 years ago, I stopped taking all medications, including vitamins, and began a health maintenance program based entirely on lifestyle control. Looking back at my history, the 20 years from 1990 to 2009, when I depended on metformin and other drugs, contributed about 91% of my cerebral microvascular calcification. In the following 16 years, from 2010 to 2025, without taking any medications for diabetes and other chronic conditions, the contribution to my cerebral vascular calcification related to my recent stroke was only 9%. On June 21, 2025, at the age of 78, I suffered a hemorrhagic stroke near the Pontine region, which has an extremely high mortality rate, above 70%. The root cause was long-term diabetes that had already damaged and calcified my cerebral vessels. The direct trigger was an acute rise of systolic blood pressure to 175 mmHg during a moment of emotional stress related to a financial investment issue. Hypertension was the triggering force for the stroke event, not the fundamental cause. This is why I now measure my blood pressure 20 to 24 times a day. In the past 7 months alone, I have collected about 30,000 blood pressure data points. By observing these data with my own eyes and analyzing them with my own brain, I have learned a great deal about blood pressure. I can now manage my stroke risk in real time using repeated measurements from my right wrist, left wrist, and upper arm to ensure consistency of trends. After entering my systolic blood pressure, SBP and diastolic blood pressure DBP into my iPhone, the system immediately displays not only SBP, DBP, and heart rate, but also for extended hemodynamic biomarkers. Pressure pulse BP reflects the combined effect of arterial stiffness and the pulsatile pressure generated by cardiac ejection and serves as a practical surrogate marker of reduced vascular elasticity. BP equals SBP DBP. An arterial pressure map represents the time average perfusion pressure that drives blood flow carrying glucose, oxygen, and nutrients to organs and is a major determinant of the chronic mechanical stress experienced by the vascular wall. Map equals DBP plus BP. 3 SBP spike quantifies the transient pressure surge and is defined as the ratio between the highest SBP and the averaged SBP over a given time period. SBP spike equals highest SBP averaged SBP. Stroke Risk Triggering Sensitivity Index (TSI) is a normalized load index that combines vascular structural condition with the instantaneous hemodynamic driving force and provides a real-time indicator of relative triggering risk. TSI equals SBP DBP over 45 SBP 120 100. Through these combined biomarkers, I can simultaneously observe the long-term structural condition of my blood vessels and the moment-to-moment hemodynamic load, allowing immediate behavioral intervention to reduce the probability of a stroke event. BP and MAP have been shown in cohort studies to predict incident stroke independently of other pressures. These 4 parameters correspond to arterial stiffness, perfusion pressure, pressure variability, and load-to-tolerance ratio, which are all independently associated with stroke risk in current hypertension and cerebrovascular research. During these 17 years of intensive lifestyle intervention, I have observed substantial functional recovery in organs that were previously impaired, including my heart, kidneys, peripheral nerves, and even diabetic retinopathy. Nevertheless, the stroke still occurred because the structural damage produced by decades of diabetes had already accumulated and had reduced the mechanical tolerance of my cerebral vessels. Vascular calcification develops within the arterial wall and represents a late-stage structural change. According to current medical understanding, this process is largely irreversible, although its progression can be slowed. In contrast, a portion of the metabolic and microvascular damage that occurs in tissues and organs such as endothelial dysfunction, early fibrosis, inflammation, and impaired perfusion can improve through long-term lifestyle modification and strict metabolic control. This explains why functional recovery is possible even when some structural defects remain. I therefore use my own body as longitudinal evidence to demonstrate the critical importance of metabolic control through lifestyle. Pharmacological therapy is highly effective in lowering risk factors and slowing disease progression, but it rarely restores organs that have already undergone advanced structural damage. In the same way, metabolic disorders cannot be fundamentally reversed by medication alone without sustained behavioral and nutritional intervention. These conclusions are not always readily accepted within the traditional medical system, which is often organized around pharmacological treatment models. However, I am a scientist, and for me the primary responsibility is to pursue and report what is physiologically and clinically true. No one has a greater responsibility for my life than I do. My goal is simple: to share these hard-earned lessons so that others can prevent the same outcome. Every life deserves to be saved. There is no need to fight any industry. We only need to tell patients the truth and give them the tools to protect themselves. TSI Engineering Definition: a normalized load index for cerebral vascular safety triggering sensitivity index. TSI is a normalized hemodynamic load index defined as TSI equals PP 45 SBP 120 100 WHERA. PP equals pulse pressure equals SBP dBP. SBP equals systolic blood pressure. Mechanical interpretation: BP 45 represents the normalized structure stiffness and fatigue damage of the vessel wall accumulated over time. SBP 120 represents the normalized instantaneous external load applied to that weakened ST or UCT. TSI is the dimensionless ratio between applied load and vascular tolerance. TSI 100 approaching structural limit, higher rupture risk. C100 controlled load, safer operating zone. A real-time structural safety system for the brain. For the past 17 years since 2010, I have continuously tracked my daily blood pressure and converted these measurements into a single quantitative EX, the triggering sensitivity index. TSI. This time-dependent curve reveals my true stroke risk in a way that isolated clinic measurements cannot. Stroke is not the result of one abnormal reading. It is the final event of a long structural weakening process combined with a transient triggering load. In 2012, my TSI reached 167, representing an extremely dangerous structural load on my cerebral blood vessels. Between 2013 and 2016, it dropped to 79, the safest period of my life. This improvement came from sustained lifestyle control, lower body weight, better glucose control, daily walking, and stable blood pressure. After 2016, the value gradually rose again with aging and increasing vascular stiffness. In mid-2025, I suffered a hemorrhagic stroke. Today, my TSI has returned to around 100 because I monitor my blood pressure throughout the day and act immediately when it rises. Technical observations of the attached TSI curves and DETOTH high-risk medication hangover 2012 to 2014. The top chart shows a starting TSI of 166.70 in 2012. This aligns with your observation that decades of diabetes and pharmacological dependency had left your vasculature in a state of extreme structural vulnerability. The steep decline immediately following this period highlights the profound impact of your aggressive lifestyle intervention. The golden period 2015 to 2017. The charts clearly identify your safest period, with a trough reaching 75.19 around 2017 Q1. During this phase, your TSI remained well below the 100 SAFTA limit, suggesting that your metabolic control was successfully compensating for existing vascular damage. The structural creep and the 2025 event 2017-2025. The quarterly data from 2020 to 2025 shows a slow, steady upward trend. Q020 Q1, 98.4420 to 4Q4, 118.9 to 2025 Q1, 120.16. This steady climb above the 100 mark indicates a loss of structural safety margin due to aging and calcification. The spike to 120.16 just before your June 2025 stroke is the mathematical smoking gun your system was operating at. A 20% overload relative to its design limit. Post-stroke recovery and real-time management. 2025 Q3 2026 Q1. The sharp drop in the 2025 Q3 and Q4 data returning to 93.66 and 98.72 demonstrates effective Venus your 20 to 24 daily measurements. by identifying spikes and intervening with autonomic techniques like for-2-way breathing. You have manually forced the TSI back into the safe zone 100. It should be noted that TSI equals 100 is defined as my personal reference safety threshold, derived from my own longitudinal data and intended solely for my individual use. In addition, I explicitly label TSI as a research hypothesis and self-monitoring tool derived from established pressure variables to prevent readers from mistaking it for a guideline-endorsed clinical index. Pathophysiology of stroke: structural damage and triggering load. Stroke risk is strongly associated with four major factors: long-term hypertension, arterial stiffness, metabolic disease such as diabetes, and acute blood pressure surge. Chronic hypertension causes structural remodeling of small cerebral arteries, including wall thickening, lumen narrowing, loss of elasticity, and microcalcification. Diabetes accelerates this process through glycation, oxidative stress, endothelial dysfunction, and chronic inflammation. These changes reduce the mechanical tolerance of the vessel wall over many years. This is the structural component of stroke. Pulse pressure is a practical clinical marker of this accumulated damage. A widened pulse pressure, for example greater than 45 mmHg, reflects reduced arterial compliance and increased vascular stiffness, and is strongly associated with both ischemic and hemorrhagic stroke. Systolic blood pressure (SBP) represents the dynamic hemodynamic load. When it rises suddenly, circumferential wall stress increases. If this transient load exceeds the reduced structural tolerance of the vessel, rupture occurs. This is the triggering mechanism. Why continuous blood pressure monitoring matters. In clinical practice, blood pressure is often measured only once during a visit. In reality, it is highly dynamic and can change within minutes or even seconds. It can be influenced by posture, activity, emotional stress, sleep, breathing, autonomic balance, and fluid status. Morning surge, stress-induced elevation, and nocturnal patterns all carry important prognostic meaning. Continuous self-monitoring transforms stroke prevention from an annual event into a real-time control process. Immediate load reduction: autonomic mechanism and practical control. Fastest method for me to reduce systolic pressure is slow breathing. Inhale for 4 seconds, exhale for 8 seconds. Repeat for 2 to 5 times. This activates parasympathetic tone, reduces sympathetic activity, lowers heart rate, decreases peripheral resistance, and reduces systolic pressure by about 10 to 15 mmHg within minutes. Quiet sitting and postponing emotional reactions have similar effects. No medication works this fast in daily life. In long-term hypertension, cerebral autoregulation shifts upward and becomes less flexible. Sudden pressure surges therefore become more dangerous, which makes immediate load reduction critical. Engineering interpretation: bridge analogy. Me blood vessels are like an old bridge. Pulse pressure (PP) tells me how stiff and fragile the structure has become after many years of metabolic disease. Systolic blood pressure (SBP) is the heavy truck traffic load that changes from minute to minute. I cannot rebuild the bridge immediately, but I can reduce the momentary load. TSI allows me to see whether the bridge is operating near its structural limit at that moment. Clinical implication: real-time stroke prevention cannot erase long-term vascular damage. Microvascular disease and calcification are the result of decades of metabolic stress. However, we can reduce the load applied to that structure at any moment. Every time I enter my blood pressure data into my iPhone app, my proprietary health maintenance medical AI software, my TSI appears instantly and answers a practical question: do I need to act right now? Stroke prevention is no longer a once-a-year clinic measurement. It has become a continuous, daily control process. I hope that this kind of instantaneous warning through PP, NAP, SBP spike, and particularly TSI can protect me from another stroke. Conclusion: a structural approach to stroke prevention. Long-term metabolic disease weakens the vessel wall, as sudden pressure surge becomes the trigger. We may not be able to quickly change the structure, but we can reduce the load at any moment. That single ability can prevent the next stroke. Disclaimer: write this article not for fame, but to explain the origin of my research approach so that readers can understand why I study chronic disease from a structural and energy-based perspective. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.